scenario of a 29-year-old man who was admitted with complaints of fatigue, anorexia, malaise, occipital headache, fever, difficulty in concentrating. So all these symptoms were present for the past 4 days. On physical examination, he appeared tired and thin. His temperature was around 101 degree Fahrenheit. So CBC was done. So what is CBC? Is a complete blood count which showed white cell count of around 3600 per millimeter cube. So directly typhoid. Why? Everyone wants to say typhoid. So typhoid. Any other options? Any other options? Low WBC count, neutropenia. Very good. So to substantiate typhoid. Anybody else want to give any other suggestions? Yes, temperature is there. So you want to say it's a case of typhoid. Again, any other differential diagnosis? We can't come to a conclusion immediately with single blood count. We can suspect, as you have discussed, but always there should be a differential diagnosis for this. Anyone wants to suggest any other diagnosis apart from this? So for anything, there should be a differential diagnosis. So can we say this is a case of FUO? What is this FUO? It's fever of unknown origin. So we can't say this as a case of fever of unknown origin because it's only of 4 days duration. Okay. So to say this is a case of FUO, the fever should last or the symptom should last for more than 3 weeks. So for 3 weeks, it should be there to diagnose as a case of FUO. Whenever there is a case of a fever with tiredness, okay, so either it could be a viral cause or it could be a bacterial cause. Either it could be a viral cause and bacterial cause, okay. So among viral, we can say it could be a case of dengue fever or it could be a case of bacterial. Among bacterial, we can say a case of typhoid or a case of TB, or we can suspect parasitical causes, that is malaria. So all these can present with fever, okay, tiredness and something. So again, differentiating features, okay. So again, this here they have come to a conclusion with CBC, okay. So what will be the pattern of fever here? So in malaria, there will be fever with chills. In case of typhoid, there will be a low-grade fever and it will be of intermittent nature. Intermittent nature. So we can better say it is a stepladder pattern of fever. Stepladder pattern of fever. And in case of TB, there will be a evening rise of temperature. So there will be a evening rise of temperature. So these are some differentiating features with respect to fever itself. Okay. And the CBC differentiate. So whenever there is a case of viral and bacterial. So what happens to the CBC? So in case of bacterial, so what happens? The neutrophil count will be increased and your lymphocyte count will be reduced, which is vice versa in case of a viral infection. Neutrophil will be reduced and lymphocyte count will be increased. But here in typhoid, what happens? In typhoid, there will be exception. Exception will be there because in typhoid fevers, though it is a bacterial fever, though it's caused by Salmonella typhi, which is a bacteria, there will be neutropenia. So that's why they have given the suggestion as both Indrajit and Nitin has given the suggestion as typhoid and Sandhya too. Right, very good. So very good guess. And these are the symptoms and clinching point. They have come to a conclusion as it's a case of typhoid fever. Okay. So this is again taken from a journal. So here they have seen many number of patients. They have compared here the healthy control. See the WBC count is around 5,000. Here the WBC count is reduced around 3,000 something. And hematocrit. So hematocrit again, what happened to hematocrit? So hematocrit is again it is reduced. So it could be a case of anemia too. Okay. So and again HB reduced, retic count it has increased. So it's a case of again, so all these patients they have typhoid along with anemia. Okay, so again we have seen here the eosinophil count is reduced. Sorry, eosinophil count is increased. So these are the interpretations in this case. So what is the cause of this typhoid fever? So as you all know, so here typhoid again is caused by Salmonella typhi, so which is a gram-negative bacilli like your E. coli, and the major route of transmission is your fecal-oral route. Okay, so either it could be a contaminated water or food, or it could be due to flies and cockroaches. Okay, and by the carriers again, who may be responsible for transmitting the infections to majority of the patients. So anyone who wants to, yes, he has given another suggestion that abscess. So here the physician has Nitin has given an option for this fever, that abscess. Again, abscess could be a reason, but here physical examination, they have said only temperature alone. So they have not mentioned abscess. So we have ruled out that. Very good. So now I want to ask one question here. So, so carriers, any interesting history for typhoid fever? Anyone who knows? Any interesting history for, yes, very good, Mary, typhoid Mary. Okay, so typhoid Mary, who was a source for spreading infections to more than thousands of patients, and yes, so I think in microbiology they could have discussed more about that, was responsible. And what is the profession of her? What is the profession of Mary? Yes, cook. Very good, excellent. So cook, who was responsible for more than 50 fatalities for this disease. Very good, very good. Yes, now we will be seeing the remaining part. So just a word about the Salmonella typhi. So this is to represent again Salmonella species. Enteric, again it can cause enteric fever, or it can cause food poisoning. Okay, again there are so many species like Salmonella typhi, Salmonella paratyphi A, B and C. Okay, so to represent Salmonella enteritidis, for which chicken is a reservoir, this is shown, and this is Salmonella typhi seagull, since gallbladder is a reservoir for this picture is shown here, Salmonella fish. Okay, so this Salmonella, for that they have shown this fish as a symbol. So, so again, here again it's motile because of H antigen, and they have drawn a lemon here. Okay, so this lemon again. So here this is Salmonella fish they have shown, and this Salmonella enteritidis chicken is a reservoir. This is to show the Salmonella typhi. So the reservoir again, the gallbladder is a major reservoir. So again they have drawn this picture of a fish to remember the salmon. Okay, Salmonella typhi, and this again it's a motile because of H antigen, and they have shown a picture of this lemon because it's acid labile. It has an importance which we'll be discussing in the next case I have shown. Okay, and they have drawn a sickle cell pattern here to show again they have exposed the bone here, so it can cause osteomyelitis in sickle cell patients. And the drug which is given for treatment is, what is this? This flour, which represents fluoroquinolones. Fluoroquinolones are the drugs given for typhoid fever. So this to show the symbol of chef, that is wearing this apron. So to remember typhoid Mary, and has rose parts in abdomen. I think in our country, majority of the patients won't develop this rose parts, which are typical of typhoid fever as given in textbooks. Here, these rose parts are not peculiar. We won't see such cases in our patients. And they have given a injection here. So injection is available. IM injection is available for treatment of Salmonella typhi. Okay. And what is this cage? So macrophages, M stands for here, M phage. Okay. So since these organisms, they enter the small intestine again, they'll be phagocytosed by your macrophages, but they won't destroy them. So it will be transmitted to the entire body. Okay. And they evade they escape from the immune system. Okay, so Salmonella typhi, this is how they spread. And this here again they have given this. So salmonella enteritis, which is this symbol shows it can cause inflammatory diarrhea. So inflammation, for that they have given this symbol. Okay, so inflammatory diarrhea. Again, it also secretes a type 3 secretory protein, again, which is responsible for causing infectivity. So this is about salmonella enteritis, which is on the left side, and this salmonella typhi on the right side. So it can cause osteomyelitis in sickle cell patients, and treatment drug of choice again, which is given as fluoroquinolones. Fluoroquinolones. So this is the image for this. And again, it has three antigens, as you all know, OH and VI. So again, the case is infectious as long as the bacilli is present in urine and feces, and there is an option, that is, there is a term called convalescent carrier, where the patients will be excreting the bacilli for 6 to 8 weeks, and chronic carrier will be excreting more than 1 year, and fecal carriers are more common when compared to the other things. Okay, she is the one who was responsible for transmitting infections to many patients, and she was also responsible for causing more fatalities. Since that time, antibiotics were not found. And these are the symptoms, overall symptoms. So stepladder fever, sweating, chills, myalgia. And one thing is, the patient might have constipation, or sometimes the patient may have pea soup diarrhea. Okay, so it's called as pea soup diarrhea. Again, with other fevers, like there can be headache, malaise, and coated tongue can be there. Okay, rose spots which are not peculiar in our patients, and relative bradycardia might be there. So this is called as Paget's sign. So so this is fever again with relative bradycardia. So again, the patient might present with abdominal pain or hepatosplenomegaly. So this again, so step 1, stage 1, stage 2, stage 3, and stage 4. So in first week, again, the patient might present with stepladder pattern of fever. Okay, so abdominal pain, myalgia, again that can be there. So fever with bradycardia. Fever with bradycardia. Again, this is diagnostic of certain infections like yellow fever also. This can be seen. This is called as Paget's sign. Paget's sign. Okay, so Paget's sign. And rose spots can be seen in some patients. Okay, splenomegaly, diarrhea, and the symptoms can progress. And again, the patient, this is very important. Again, the patient may appear toxic and anorexic in typhoid. Okay, and there can be weight loss, even hair loss can be there. So any chronic illness again can produce hair losses, and it can produce complications like hemorrhage and perforation. So hemorrhage and perforation can occur. Okay, so untreated, again, they may land up in complications, and some may progress as carriers. So these are the tests. These they could have discussed in micro. So first week, again, blood culture will be more sensitive. In second week, Vidal, because Vidal becomes positive only after 7 days of fever, and stool culture again, which will be useful in week 3 of fever. Okay, week 3. So this is just to show Vidal test. So O antigen and H antigen. So titers of O antigen, again, if it is present in more equal to or more than 1 in 160 dilutions, again, it's said to be positive for typhoid fever, and for H it is 1 in 200. Okay, so this is just a word to show what are the investigations you have to look for Vidal test. Now, so we'll come to our part, that is drugs. So what are the drugs which are given for management of typhoid fever? Yes. So now you can discuss. Very good. Ceftriaxone. Any other thing? Ciprofloxacin. Very good. Fluoroquinolones. Yes, that group of drugs. Any other group of drugs apart from fluoroquinolones? Azithromycin. Yes, very good. So for a patient, so for carriers, ampicillin. Okay. So you want to, if you want to choose one particular drug, which drug will you choose? So there are so many options, like we have mentioned azithromycin, ciprofloxacin, we have mentioned ceftriax. Yes, you want to choose. So depending upon the patient, you have to choose. Depending upon the patient, if there is no complications, so you can go for fluoroquinolones. Okay, fluoroquinolones, ciprofloxacin. So again, ceftriaxone can be given for multi-drug resistant typhoid fever, and it can also be started empirically also. It can also be started empirically also. So here, so fluoroquinolones like ciprofloxacin. So all these drugs, here you can commonly see they are given for 2 weeks. They are given for 2 weeks duration. So fluoroquinolones, commonly ciprofloxacin is preferred. So it's given in the dosage of 750 milligram. So twice daily for 2 weeks. And ceftriaxone, again, it is given parenterally. So ceftriaxone, I think you still remember to which generation it belongs. So it belongs to third generation cephalosporins. Again, ceftriaxone is given 2 gram intravenous. Okay, so twice daily and is given for 2 weeks. We can also use cefatoxime in particular cases that I'll discuss later. And azithromycin can also be given as an alternative. Okay, so 500 milligram once daily for 7 days. So we'll discuss in which cases we'll be using this. So, ciprofloxacin, again drug of choice. Ceftriaxone can be given for empirical treatment and also for treatment of multi-drug resistant case. And the ciprofloxacin can also be given for carrier state also. Apart from treatment of acute typhoid, it can be given for carrier state also. Okay. So when you want to give a drug orally, so if the patient is not willing and you think he can be started orally, so there is no need for IV injection. So in those patients, you can go for cefixime. I think you remember this group of drug which comes under cephalosporins again, which is a third generation drug. Okay, cefixime you can give orally. Again, it can be given in the dosage of 200 to 400 milligram twice daily for a period of 2 weeks. And these are the other drugs. So Septron, that is cotrimoxazole, 1 double strength tablet given twice daily. So all these for 2 weeks. Or you can go for amox or ampicillin. Either amoxicillin or ampicillin can be given. Ampi, which is given parenterally. And chloramphenicol orally. Since these drugs are not preferred because of adverse effects, bone marrow suppression. Okay. So, and resistance also has developed to these drugs. So, these are the treatment options available for management of typhoid fever, and you have to decide so which you are going to choose according to the patients. So, what are the drawbacks of cephalosporins? Yes, with respect to age group, with the interactions with respect to age group for fluoroquinolones, with respect to age group, ciprofloxacin. Typhoid fever is again not common in children, but fluoroquinolones can it be preferred for children? If not, why? If not, why? It's not kidney, it's not the answer. Pregnant women contraindicated, very good. Yes, very good. So arthropathy, tendinitis, okay. So arthropathy, it's not given in children less than 12 years of age and also in elderly. Very good, arthropathy. That is the drawback. And again, it's contraindicated in pregnancy too. So which are the drugs safe in pregnant patients with typhoid fever? Pregnant patients with typhoid fever. Which are the, entry fever, anything. So azithromycin is safe. Even your beta-lactams, very good. Even your ceftriaxone is safe in pregnancy. So ceftriaxone, very good. So ceftriaxone is safe in pregnancy. Ceftriaxone and azithromycin can be preferred if a pregnant patient presents with this enteric fever. Okay. So what are the drawbacks of ceftriaxone? What are the drawbacks of ceftriaxone? I'm not asking. Yes, very good. Parenteral, very good. Parenteral. So if the patient wants, if he is not willing, if he or she is not willing to admit, they want a oral drug means, then it could be a problem. So ceftriaxone, only thing is it could be given parenterally. Okay. So these are the other discussion in this group about the drugs. Okay. And pregnancy, we have discussed both ceftriaxone and azithromycin is safe. What happens to children? So children, will you give ceftriaxone for children with enteric fever? Anyone? For children with enteric fever, will you give this? So which drug to be given? Which drug to be given? Cefixime, cefotaxime, very good, cefotaxime, okay. Cefotaxime is an alternative to ceftriaxone. We saw that in cephalosporin's class, okay. So cefotaxime is an alternative, yes, interferes with your bilirubin metabolism. So we have to go for cefotaxime in children. Yes, very good answer. So this is a first case scenario. This is a case scenario of a 28-year-old psychiatric PG who had symptoms of fever on and off for 2 weeks. He also had tiredness and fatigue. After 5 days of these symptoms, he took ofloxacin 400 mg BD for 5 days. But the symptoms persisted. Before the onset of this fever symptoms, he had heartburns for which he took omeprazole for 1 week. Since the symptoms persisted, he went for investigations. So, does omeprazole has anything to do here? So, omeprazole, as you all know, omeprazole is a proton pump inhibitor. So, what does it do? What happens to the acidity of the stomach? So, proton pump inhibitor is used for treating peptic ulcer. So, what happens? So, the acidity of the stomach, it will be reduced. So, Salmonella typhi is a acid labile. So, whenever the acidity is reduced, again Salmonella typhi can easily infect the person. So, omeprazole. So, since there is suppression of acid, so what happened? Easily he got infected with this Salmonella typhi infection. So, which is acid labile. So, the stomach acidity itself will kill this bacteria. Since he was on PPI, so it easily infected. So, this is one relevance of omeprazole. And other things, so why this ultrasound abdomen was done? So, USG abdomen, again there might be splenomegaly in case of typhoid. So, splenomegaly was there on ultrasound abdomen. Will there be any finding in CT? So, CT abdomen, not for all cases, there might be mesenteric lymphadenopathy. Mesenteric lymphadenopathy might be there. So, these are about the investigations. And blood culture, as we already discussed, in the first week of infection, it will show maximum positivity. So, this is a Whitehall report. So, here we have seen, so 1 in 160 dilution. So, O and O antibody and H. So, here, so it's positive for Salmonella typhi. Okay. So, this is the history of my husband who got admitted for typhoid fever infection, and this was a treatment given for him. So, IV fluids for correcting dehydration, and augmentin was given parenterally for 10 days and followed by oral augmentin for 1 week, and pantoprazole injections and vitamin supplements were given. So, what is this augmentin? So, augmentin is a combination of amox and clavulanic acid. So, as we all know, so either amox or ampicillin can be given for treatment of typhoid fever. Okay. So, since majority of the bacteria, they produce resistance by producing beta lactamase. So, easily resistance can develop when you give either of these drugs, amox or ampicillin. So, the physician has combined him with amox with clavulanic acid. So, clavulanic acid is a beta lactamase inhibitor. So, clavulanic acid is a beta lactamase inhibitor. So, he has combined amoxicillin and clavulanic acid. So, that is your augmentin. Okay. So, augmentin was given for 10 days followed by oral augmentin for 1 week. Okay. See. So, practical difficulties again. So cost matters. So whenever you need hospitalization for 1 week, so many patients will not be willing. If the symptoms start improving in 2 to 3 days, they want to be discharged. So they'll be saying that they can come in the morning and evening for getting the parenteral injections, or they want to give them oral tablets. Okay. So this is one major factor. In periphery and all, patients won't get admitted for 1 week and spend their money. So these are some practical difficulties. And also if the fever is not subsiding, many of the patients will be taking self medications like paracetamol, and some even may go and directly see the Vidal. They'll come with that report, and they may say that, sir, I'm having typhoid. So these are the situations faced by doctors in rural setups. So they majority, as we have seen empirically, we can start ceftriaxone. So ceftriaxone will be given for that patient. So before waiting for the blood culture report, and again the patient may get easily improved, because ceftriaxone is again a drug of choice for treatment of typhoid fever. Okay, and here the physician has started on augmentin. So is there any important thing to be seen with augmentin? Okay, so augmentin is, again we know, it's a combination of amox and clavulanic acid. Okay, so amoxicillin, again, which belongs to penicillin group. So the most important thing to be kept in mind is anaphylaxis. So anybody can get this anaphylaxis. So when we give a parenteral injection, so we should be very cautious. So the physician who treated this patient, so started augmentin in 100 ml saline using pediatric IV setup. Okay, so he started augmentin on 100 ml saline, and again so it was given slow IV, so to avoid anaphylaxis. Okay, so for any patient, if you are starting this penicillin group, so either you have to give a test dose. Okay, and another thing is you can dilute it and give augmentin, which is again available in powder form. Okay, so it should be diluted in distilled water, and when it is given in a drip, again there is very less chances of developing a sudden anaphylaxis. If at all any symptoms are there, the physician can easily pick up. Okay, so this is another important point in treatment purpose. So even I have seen a case of amoxicillin death during my CRRI. So ampicillin death, sorry. So ampicillin parenteral was given. Okay, so without giving a test dose by one of the CRRI, the patient expired. So anyone can get anaphylaxis. So we have to be very cautious while administering penicillin group of drugs. With respect to carriers, how long you have to treat carriers? The same 2 weeks or something else? So carriers, they need to be treated for, yes, very good, excellent, 6 weeks. So carriers, they need to be treated for a longer period. At least remember that, longer period. So if you are going to use ciprofloxacin, so you have to give ciprofloxacin for a period of 28 days. Okay, so for a period of 28 days. So ciprofloxacin twice daily for 20 days. If you are going to give amox or ampi, you have to give along with probenecid, or you can give for cotrimoxazole. So again, this is given for a duration of 6 weeks. That should be remembered. So carriers, treatment of carriers is different from cases. Okay, and cholecystectomy can be done in case of chronic carriers. Cholecystectomy, and this was suggested for typhoid. That is Mary, who was having infection in gallbladder in her postmortem. She was advised to do cholecystectomy when she was infecting many people, but she denied to undergo this procedure. So this is about treatment of carriers. And lastly, a word about vaccine. So vaccine, I think, is not more protective. There are two types of vaccine. One is the oral vaccine and another is an intramuscular vaccine. So oral is type 21A vaccine. So 3 doses to be taken 0, 3rd and 5th day. So it should be given in case of every 3 years in case of endemic areas, and every year for travelers going to endemic areas. It's available as oral enteric coated tablets. And this is VA polysaccharide vaccine, so which is given a single dose every 3 years. Okay, and it is given intramuscularly. Okay, so this is about vaccine. And lastly, our overall view of typhoid. So, which is caused by salmonella. This is salmonella typhi. Okay. Again, what happens? This gallbladder is a reservoir of infection. Okay. So this is moon and monkey. So monocytic. So monocyte again it's engulfed by your macrophages. So which via which it is carried throughout the body. Okay. And you can see here fever. This is a picture showing fever. Okay. And again there will be abdominal pain. Here you can see abdomen which has roses. So rose parts. Again it can cause constipation as well as diarrhea. Okay. So this is a closed one and here that is an open one. So constipation, or it can cause pea soup diarrhea. It can present in any way. And here we can see what is the treatment options. Here we can see a chef having 3 axes. Okay. Chef having 3 axes, ceftriaxone, and this is a queen. So fluoroquinolones again, which are the drugs which are used in management of typhoid fever. And again vaccines, we can see a live vaccine is available. Okay, so which is given orally, and another one vaccine which is given intramuscularly. Okay, so which is a VA polysaccharide vaccine. Okay, so this is overall management of typhoid fever. Okay, so I think you have understood